The broadcast is now starting. All attendees are in listen-only mode.
Hello, Dr.
Segal.
Thank you. Hello, my name is Eric Segal. I am a pediatric epileptologist at the Northeast Regional Epilepsy Group. I am based in Hackensack, New Jersey, and I am the Director for Pediatric Epilepsy for the New Jersey portion of our group. At Hackensack, I help run the ketogenic diet program as well as the Dravet program and tuberous sclerosis program. And what we are going to talk about tonight, what we'll focus on is neuromodulation and the role of neuromodulation in the treatment of epilepsy. So let's get started. There we go. Okay, so the goal of treatment of epilepsy is to eliminate seizures without a significant impact on behavior or cognition. So here we want to make sure that there are 0 seizures, but at the same time, if we were to have 0 seizures and yet a person was very sleepy or very irritable, that would not be an effective treatment. Similarly, if a person continued to have seizures but did not have any side effects, that's also not an effective treatment. So the goal for treatment of epilepsy, the goal for treating all seizures, is to eliminate seizures without significantly impacting behavior or cognition. For everyone who walks in the door, first time they have a seizure, the initial therapy that we pursue is pharmacologic, it's medications. And more than 50% of patients can become seizure-free with that initial therapy. However, if patients take adequate doses of the appropriate selected medications, there still is a very large minority of patients that have medication refractory epilepsy, that the medications don't work. So that's around 20% or a little bit less than 20% of patients who will not be seizure-free despite multiple medications. And that is what neuromodulation is for. That's what we're going to focus on, is a group of patients who, despite good choices in terms of medications, still continue to have seizures. So what is the definition then of a medication failure? When do we say that that a person has failed medications and we should consider non-pharmacologic or non-medication therapies? Well, we feel that when medications do not prevent seizures or the side effects become intolerable. So what that means is that a person is not responding to the medication because either they're having horrible side effects, or just despite good doses or maximal doses on that medication, they're still having breakthrough seizures. So that would be the medication failure. Medication failure is when they still have seizures despite maximal doses, or if there are significant side effects. And for those patients, we would consider non-pharmacologic therapies. Now, the non-pharmacologic therapies, the first one that we consider is epilepsy surgery. The epilepsy surgery that we mean here is a resective surgery where part of the brain that is actually causing the seizure is removed. And that is the gold standard for someone who does not respond to medications. However, not everyone has that type of epilepsy where you can simply go and take out one small part of the brain, leaving the rest of the brain intact, and make that person seizure-free. So for those patients who epilepsy surgery is not a possibility, we would consider something like diet therapy, such as ketogenic diet or modified Atkins diet or low glycemic index treatment diets, or we would consider neuromodulation. So these are the 3 non-pharmacologic therapies that we consider once we deem that a patient is not going to respond to seizure medications. So now, here we are. Let's talk about neuromodulation. Now, neuromodulation, to understand what neuromodulation is, first we have to go back and understand what a seizure is. Now, a seizure is caused by a synchronized firing of an inappropriate network of neurons. So an inappropriate network of neurons can either be nerves that should never have been connected, should never have formed a neural network, are now talking to each other, or nerve cells that are appropriate to be connected but are firing the wrong way. They're firing in an inappropriate way. So either if you have the wrong nerves connected or the right nerves connected but firing the wrong way, this can cause a synchronization that takes over the natural activity of what the nerve cells are supposed to be doing, and that is what causes the seizure. So the same way that we look at electricity and a synchronization of electricity causing the seizure in the brain, the idea for neuromodulation is to use an electrical current to suppress that firing or to interfere with that synchronization, to break up or desynchronize the firing and to stop the seizure. So the idea here is by using electrical stimulation, we can change the neural networks over a period of time and prevent the seizures, or we can use neurostimulation to stop a seizure in its tracks. That is the idea behind neuromodulation. Now, the patients who we would consider appropriate for neuromodulation or neurostimulation will be patients with multifocal epilepsy. Multifocal epilepsy describes patients who can have seizures from multiple parts of the brain, or patients where we don't know where the seizures are coming from exactly. They have an unclear seizure generator. So despite multiple EEGs capturing multiple seizures, it's still not clear exactly where the seizures are coming from. Or the seizures themselves may be generalized, meaning both sides of the brain are having a seizure at the same time. So that would be an unclear seizure generator where we can't find the actual pinpoint, the one spot where the seizures are coming from. Now, another issue that can happen is that you have a patient who has a focal epilepsy. A focal epilepsy is where the seizure comes from only one part of the brain, and the rest of the brain is not having a seizure. However, the problem is that seizure generator is very close to eloquent cortex. Eloquent cortex implies that a patient's seizure is coming from part of the brain that is very close to something very important that the brain can do, such as controlling language, speech, or using your hand, something like that. So if there's a seizure generator, excuse me, that overlaps with eloquent cortex, we would be concerned that if we remove that part of the brain, then that patient may have seizure freedom, but at a significant loss because they have now lost something very important to their lives, such as speaking or using their hand. Finally, patients who are opposed to brain surgery, they just don't want it. It sounds very risky. They're worried about it. So this group of patients you would also consider for neuromodulation. So here we have the 4 indications for neurostimulation: multifocal epilepsy, seizure generators that we can't find, overlapping eloquent cortex, where we're concerned that by doing an actual surgical resection, we can actually do some other form of harm by doing the seizure resection, or patients who are opposed to brain surgery. What types of neuromodulation are available? So currently, the 2 types that are FDA approved include the vagal nerve stimulator and the responsive neurostimulation, also known as NeuroPace. Deep brain stimulation is kind of the midway point in the FDA approval process. Trigeminal nerve stimulation and transmagnetic stimulation are being used in certain centers. They are not FDA approved, and more studies are being done to learn more about how effective they are as different therapies. So the way the order of this is going to go is we'll first go through the vagal nerve stimulation, we'll touch on the deep brain stimulation, and then we'll come back to the responsive neurostimulation. These 3 devices are internal devices. These are devices that we implant surgically. The trigeminal nerve stimulation and the transmagnetic stimulation, the 2 ones that have the stars, the asterisks next to them, so those are devices that are external that do not require any surgery to use them. And we'll discuss all of these modalities now. We'll start with vagal nerve stimulation. Vagal nerve stimulation, or the vagal nerve stimulator, is by far the most common device used for neuromodulation in patients with epilepsy. It's been around the longest. All these other devices are much more recent compared to the vagal nerve stimulator. The way the vagal nerve stimulator works, using this cartoon depiction provided by the company Cyberonics that makes this device, is that there is here a generator that is surgically implanted in the chest, and it's connected to a wire that goes to what's called the vagal nerve. And here you see that the wire coils around the vagal nerve. And what this does is that this vagal nerve stimulator generator sends an electrical impulse. Typically it sends an impulse for about 30 seconds and off for 5 minutes, on for 30 seconds, off for 5 minutes. This vagal nerve will then transmit the electrical impulse deep into the brain, and then from within deep in the brain, it will spread out diffusely throughout the brain and hopefully disrupt these seizure networks. Now, this is not brain surgery. This is away from the brain. This is a surgery that is done, again, at the chest and the neck level, and not the brain itself. So let's talk a little bit more about the nitty-gritty with the vagal nerve stimulator. Now, the vagal nerve stimulator, the generator itself can be adjusted. Here you see the doctor using a Palm Pilot, and there's a paddle that is then put up against the chest. And by using the Palm Pilot and the paddle, we can adjust the settings. So the vagal nerve stimulator, when it's first implanted, it's actually not really turned on. It's turned on as a test, and then it's turned off again. And the patient comes in the office every 2 to 4 weeks to further adjust the vagal nerve stimulator and to keep on increasing the settings. By doing so in a gradual way, we can prevent side effects. The body gets used to the stimulation, and we titrate to effect. So we push up the levels of stimulation in order to get the effect that we're looking for, which is the elimination or decrease of seizures. Now, so this is programmed by this non-invasive paddle. What you should know is that the battery can run out. So that generator that we saw before over here has the battery, and the Palm Pilot and the paddle can see how much energy is left in the battery, and that may need to be replaced from time to time, which is, again, done through a surgery. In addition to the paddle that is being used here, there is a magnet that's provided for the patient or the patient's family. And what this magnet is used for is that if a person is either having a seizure or think that they will have a seizure soon, the magnet can be slowly swiped across the vagal nerve stimulator generator, and that can cause the vagal nerve stimulator to transmit an extra signal, an extra impulse, to hopefully stop or prevent that seizure from happening. So, how well does it work? Looking at most of the studies, what we see is that the 50% responder rate, that is, a 50% responder rate refers to how many patients had their seizures cut in half. So what we see is at the end of 3 months, the 50% responder rate is about 23%. So 23% of patients had their seizures cut in half using a VNS after 3 months. Now, that number gets better by the 1-year mark. So what's interesting here is by 1 year, about 35% of patients had their seizures cut in half. Now, that's actually something that is worth pausing for, because when it comes to medications, with many people with medications, we find that there's a honeymoon period where the medications work initially, and then they stop working. But the literature shows with the vagal nerve stimulator, and really with neuromodulation in general, the numbers get better the longer it's in. The seizure control improves the longer that the device is being used. The median reduction is that seizures are reduced somewhere between 28 to 45%, depending what study you're looking at. So this is pretty significant. So the seizures do get better, and with the vagal nerve stimulator, we see that that they get better over time, and it continues improvement. Now, I put the slide in here to discuss Lennox-Gastaut syndrome. As you know, I'm a pediatric epileptologist. Lennox-Gastaut is one of the more difficult epilepsies that we treat. These patients typically are not eligible for epilepsy surgery, and I find that looking at kind of the hardest cases to treat is very helpful to determine how effective this may be in really the most severe cases. And what we see is at 6 months, about 27 to 64% seizure reduction. Half of the patients had their seizures reduced by 6 months, and about 65% patients will have half their seizures cut at 12 months. Drop seizures is part of the Lennox-Gastaut syndrome. So Lennox-Gastaut really implies a particular EEG pattern for patients with intellectual disability who have multiple seizure types, including drop seizures. And so the vagal nerve stimulator can actually decrease the number of drop seizures by as high up to as 88%, which is significant. So what are the side effects? What are the problems with the vagal nerve stimulator? So of course, this is a surgery, but it's not brain surgery. And in fact, the infection rate with the vagal nerve stimulator is very low. About 3% of patients will have an infection, but only 1% of patients total have such a significant infection that it requires taking out the device itself. The most common side effects has to do with hoarseness and voice alteration, and that's because the vagal nerve, the nerve that's being stimulated, affects multiple different parts of the body, including the vocal cords. So hoarseness and voice alteration is the most common. Throat pain is next, and cough at the last is probably the third most common, and the third most common here means 7% of patients. So that's not so, it typically is not such a problem, but it can happen. I think the take-home message here is, unlike the medications that we know so much about, there is no sleepiness, there's no drowsiness, there is no irritability associated with the vagal nerve stimulator. In fact, there is an FDA approval for using the vagal nerve stimulator for patients with depression. It's typically not done because the psychiatrists can't get insurances to pay for these procedures for depression, but VNS has an approval for both epilepsy for epilepsy patients as well as patients with depression. So that's a significant advantage, obviously, because a lot of patients with medication-refractory epilepsy do have depression. So that's something that's very positive, and again, it doesn't come with the drowsiness or the sleepiness or the cognitive slowing that many medications do. Additional considerations that you have to be aware of is that the generator can be removed. It can be taken out, and we've discussed that earlier, that sometimes the battery needs to be replaced, for example. However, the wire that is attached or looped around the vagal nerve stimulator can form scar tissue around the vagal nerve itself, and generally surgeons do not want to remove the wire that's coiled around the vagal nerve for concern of actually damaging the vagal nerve itself. So the wire many times will stay in even if the generator is removed. Now, patients who have a vagal nerve stimulator can have an MRI of their brain as long as the MRI has a specific coil called a send and receive coil. Patients who have the vagal nerve stimulator usually at this point are not allowed to have MRIs of anything below the brain at this point, but they can have MRI of the brain as long as they're in a specific scanner that has that type of coil. So I think this is important because here, we're talking about patients who have different types of epilepsy, and even though there's really, they can't have epilepsy surgery, many patients who we would consider for vagal nerve stimulator, we also consider for a corpus callosotomy. So the corpus callosum is a very thick white matter tract. It's one of the largest white matter tracts that connects both the right and the left hemisphere. And a corpus callosotomy is a surgical procedure where the surgeon really severs either the front 2/3 or the entire corpus callosum, severing most of the connections between the two hemispheres. And corpus callosotomy can be an effective treatment for seizures. So so some people will try to weigh whether or not they should go for a vagal nerve stimulator versus a corpus callosotomy. So to answer that question, I put together a slide. There's only 2 studies comparing both procedures, and both have only a small number of patients. And what is found is that the vagal nerve stimulator is less invasive, right? It's not brain surgery, so therefore it is a lower risk procedure. What's significant here is that the vagal nerve stimulator efficacy, how effective it is, can be improved over time. As we said before, the longer it's in, the more effective it is. But the caveat is that it can take a while to actually see that improvement. So some patients have to wait up to 6 or even 12 months to see the full effect of the vagal nerve stimulator. So it's not as though it's implanted and then, boom, right away you see seizure reduction. It does take time. It is a gradual process. The corpus callosotomy, on the other hand, is slightly different. The corpus callosotomy, there's a higher risk of complications, but because it is brain surgery. However, the percent risk of complications with the corpus callosotomy is still low compared to other types of brain surgery, so that needs to be stated. Unlike the vagal nerve stimulator, there is an immediate improvement. You see right away that the seizures get better. However, it doesn't get better further. So what you see is what you get after the surgery. The longer time passes since the corpus callosotomy, it's not as though the seizure efficacy improves anyway. And what's really found is that the corpus callosotomy is very effective for drop seizures. These are seizures where patients fall to the ground, as we discussed with the Lennox-Gastaut syndrome, but it's not as effective for the generalized tonic-clonic seizures. This is different compared to the vagal nerve stimulator, which is effective for all types of seizures, as opposed to being only effective for one particular seizure type. Okay, so let's pause here for a moment. What we've discussed so far is the definition of a seizure, the definition of medication-refractory epilepsy, the role of neuromodulation in the treatment of epilepsy, and the different modalities, different types of neuromodulation, vagal nerve stimulation, deep brain stimulation, responsive neurostimulation, transmagnetic and trigeminal neurostimulation. And we've gone through the vagal nerve stimulator, which is the most common form of neurostimulation up to this point. And now we're going to move on to deep brain stimulation. So deep brain stimulation is not new. Deep brain stimulation is currently being used in the United States for patients with movement disorders, such as Parkinson's or chorea. It's deep brain stimulation deep brain stimulation, essentially what's being stimulated in the movement disorders is similar to what's being stimulated in patients with epilepsy. So the same targets that we look at for movement disorders with deep brain stimulation are the same targets that we use for patients with epilepsy. How is deep brain stimulation done? So what you see here on the left is a stereotactic frame where a patient, before this actual portion of the surgery happens, has an MRI, and this frame is placed over the head, and this device is used, and it's almost like a GPS for the surgeon to know exactly where they are in the brain. And then they can take a probe and they can touch it to the head, and they can see exactly what part of the brain they're targeting. And so for the deep brain stimulator, essentially there are two different generators that are placed here near the surface, with wires going down to the deep portions of the brain, to the deep structures that we will discuss next. Sorry about that. 1 second, please. I apologize for that. The deep brain stimulation. This is exactly what we're stimulating. We're stimulating the thalamus. The thalamus, the brain actually has two thalami here, and this is deep in the brain. The thalamus, the purpose of the thalamus is a relay station between the brain and the rest of the body. So what you see here on the surface of the brain is the cortex, and the cortex sends signals to the thalamus, which then sends signals to the rest of the body, and vice versa. So your nerves from your fingertips or your toes also send sensory signals that go up to the thalamus that then go up to the surface of the brain as well. Now, there are many small structures in the thalamus called nuclei. Now, the nuclei that we're most interested here is going to be the anterior nucleus, which is here. Anterior actually means front, so it's over here, as well as the centromedian nucleus as well, which I will show in a different slide. And so these are the areas of interest for treatment of epilepsy as well as for treatment of movement disorders. Why do we choose these nuclei? There's so many, as we just showed here on this picture. So why do we pick these nuclei? So these nuclei are chosen because we feel that these nuclei are involved in the seizure networks that we'll show in a moment. So generalized seizures, these are seizures that start from both sides of the brain at the same time, likely come from deep structures within the brain. And they use these relay stations. They use these small nuclei within the thalamus to communicate with the cortex. And it's the cortex that we see on the EEG. That is the surface of the brain that we see on the EEG propagating the seizure. The other reason to consider these particular nuclei is that they are inhibitory neurons in the brain, meaning that they have the ability to stop other neurons, other nerve cells from firing. So the anterior nucleus of the thalamus, which is here in this picture, is involved in this circuit called the circuit of Papez. And the circuit of Papez is seen in animal models to be integral in the propagation of a seizure. This anterior nucleus of the thalamus can transmit inhibitory signals to this Papez circuit, and it could stop a seizure or prevent one from coming. The main trial, the main study that we talk about when it comes to deep brain stimulation and using the anterior nucleus of the thalamus is the SANTE trial. The SANTE trial stands for Stimulation of the Anterior Nucleus of the Thalamus. And it's a double-blinded, placebo-controlled trial for patients who have focal seizures or partial seizures. And what was found is that at the 3-month mark, about 40% of seizures were reduced. That's the median, and that was the blinded period. After everyone was unblinded, and so everyone's deep brain stimulator was turned up to the appropriate levels, it was found that there was about a 56% median reduction, and about a little bit more than half of patients had their seizures cut in half. The numbers get better as the time goes on. As you see here at the 5-year mark, about 69% of patients have their seizures cut in half, and about the same number of seizures are reduced. So about 69% of patients, about 69% of seizures decrease, as well as about 69% of seizures are cut in half. So those numbers actually do look quite good. The problem here that they ran into SANTE trial is that there was a significant placebo effect for the sham group, meaning the group that did not have the appropriate stimulation, which is, I think, has led to a little bit of a delay in terms of getting an indication for epilepsy patients. The side effects of this procedure really have to do with the fact that it's brain surgery and where these leads and these electrodes are being placed. So about 18% of patients have paresthesias. Paresthesia implies changes in sensation. About 10% or 11% of patients actually have pain at the site where the device is implanted. Almost the same number of patients, 9% of patients will actually have infections at that site, and 8% of patients will need to have the leads that connect from the generator to the thalamus replaced. Okay, now another form of stimulation, this is just really to be complete. It's not really being currently used or considered in the U.S. at this point, but it's centromedian, the centromedian nucleus of the thalamus. The centromedian nucleus of the thalamus is part of the reticulo-thalamo-cortical system. The reticulo-thalamo-cortical system is how your body helps regulate when you're asleep and when you're awake. And using a similar concept here, the centromedian nucleus communicates with multiple parts of the brain and can adjust the seizure networks. And so what we find in animal models that high-frequency stimulation of the centromedian nucleus can actually cause a desynchronization of the seizure on the EEG. Again, it can disrupt the seizure on the EEG. So the best study I could find was an open label trial, means that everyone was given the stimulator and everyone knew it. And it was in 13 patients with Lennox-Gastaut syndrome, and it was found that for those patients, the overall seizure reduction was at 80%, which I know sounds good, but what we need to keep in mind is that it's open label, so there may be a placebo effect, and it was only in 13 patients, so it's hard to say, it's hard to generalize that to a larger population. In a smaller study that was double-blinded, there was about a 30% decrease in generalized tonic-clonic seizures compared to the 8% who had the placebo arm, and that's only in 7 patients. But I have a feeling that the numbers, if they were studied for a larger group of people, it would be closer to this 30% mark than the 80%, and that there would be a 30% decrease in seizures as opposed to this 80% decrease. Okay, so lastly, one more form of stimulation to consider is the cerebellum. So if we think of the brain as being broken down into 5 lobes, we have the frontal lobe in the front, the occipital lobe in the back, the temporal lobe by the temples, the parietal lobe in between the frontal and the occipital lobe, and then down here we have the cerebellum. And the cerebellum is the part of the brain that is typically thought of for control of movement and balance. And the reason why the cerebellum was considered as a potential site for stimulation to prevent seizures is that the cerebellar nerves are mostly inhibitory, meaning that they send negative signals that can stop other nerves from firing. So the idea here is that the inhibition of the hippocampus, the idea here, let me start that again. The idea here is that you can use electrical stimulation from the cerebellum to stop a seizure in other parts of the brain. But the problem with that theory is that not only can stimulation of the cerebellum send inhibitory signals to other parts of the brain, but stimulation of the cerebellum can also cause itself to stop firing, meaning that the cerebellar fibers can send inhibitory signals to other parts of the cerebellum and stop it from firing further. So I think the take-home is that we're not totally sure how cerebellar stimulation really would work. And there was only a very small group of patients that were tested. It was 5 patients in a randomized control study, and where the stimulator was placed in a particular part of the cerebellar cortex. And what was found is that the generalized tonic-clonic seizures were decreased by 24% on average, tonic seizures, which is the stiffening, by 54%, and drop attacks by 35%. But the problem that happens here is the side effects, is that there's an electrode migration that occurs, meaning that the electrodes moved and had to be reoperated on, so that 3 patients required repeat surgery. 1 patient had an infection, and 1 patient had difficulty walking. So that's pretty significant, and I can't see that really taking off when there's other better studied modalities that are already being proposed. Lastly, for completeness sake, there's a subthalamic nucleus, which can also be stimulated. It's an area right below the thalamus. It's an area that is used in movement disorders. There was one study where 9 patients were implanted, and there was an up to 80% seizure reduction. But similar problems to what you expect with other types of deep brain stimulation. There was some mild facial twitching, numbness in the extremities during adjustment. All right, so that ends the deep brain stimulator as we know it. Again, the deep brain stimulator is similar to the vagal nerve stimulator, that it kind of turns on and turns off automatically. And what we're going to move on to next is what's called a closed-loop device, known as NeuroPace, or responsive neurostimulation, RNS. Now, NeuroPace and responsive neurostimulation has a very different idea, and for a very different group of patients. And it is FDA approved now to be used by the general epilepsy public. And what this is is there is a generator that is implanted in the head, and this generator connects to one or more leads, one or more electrodes that can sense and pick up the signal of when a seizure is starting and emit an impulse to stop a seizure in its tracks. It is a defibrillator for a seizure. So that's a very different way of approaching, as opposed to the turn on, turn off automatically. This turns on theoretically only when it needs to. And the brain is stimulated when a seizure is detected. Now, as you may imagine, this is not going to work for all types of epilepsies. If you have a generalized epilepsy, this is not the right therapy for you. However, if you have focal seizures, and those focal seizures are, let's say, occur in more than one site, they're multifocal, such as bitemporal lobe epilepsy, or the seizures occur close to the eloquent cortex, and so therefore surgery is not an option, these are the patients that this device would probably be best suited for. So in the major study that was done for NeuroPace, or responsive neurostimulation, 191 patients were implanted. They were randomized. There was a sham group where they were given kind of like a placebo stimulation, and then there was another group, the treatment group, that actually got the effective doses of stimulation. And what we found, or what they found rather, is that there was about a 38% decrease in seizure frequency compared to the sham group, and about 1/3 of patients had their seizures cut in half. Now there was no significant difference in the side effects among the groups when they were blinded, and the side effects typically consist of headache, dysesthesia, which is again this unusual sensations, and sometimes increased seizures actually. Now this is called a scout film. It's basically an X-ray that's done prior to performing a CAT scan, and here you see the generator as it's implanted in the skull with the electrodes that lead from there to the seizure generators. So that's confusing, right? We've gone through numbers that sound kind of similar for different devices. So how do we put it all together? If we try to compare these three different types of devices, so let's look at the anterior thalamic nucleus stimulation, the vagal nerve stimulator, and the cortical stimulation using the NeuroPace, the RNS, the responsive neurostimulation, and let's look at those together and see what the differences are, which ones may be better for different patients. And what we see here is that the numbers actually look very similar. The percent seizure reduction during the blinded period for vagal nerve stimulator in these two different studies was between 25 and 28% seizure reduction, about maybe 40% or 38% for the deep brain stimulation, whether it's the responsive neurostimulator on the cortex or the deep brain stimulator of the thalamus. At 1 year out, the numbers get better. The numbers get better across the board, pretty much around the same rates. So vagal nerve stimulator goes up to 43 to 45% seizure reduction. It sits here about 40% again for the deep brain stimulation. And when we look at the responder rates are how many patients had their seizures cut in half. Again, we see similar numbers. The vagal nerve stimulator, between 23 and 31% of patients had their seizures cut in half. For the cortical stimulation or responsive neurostimulation, again, about 30% of patients. And at the 1 year mark, the numbers go up slightly. So from 23 to 35% of patients had their seizures cut in half with the vagal nerve stimulator. Still sitting on 43% for the thalamic stimulation. And then the NeuroPace device also goes up to about 43%. So that's confusing, right? So how do you know which device, if they all sound kind of similar in terms of their numbers? So I think it really depends on the type of epilepsy. If a person has a generalized epilepsy or more than 2 sites where the seizures can come from, then the responsive neurostimulator, the NeuroPace, is not the device for that person. But if a person, so you would consider something like the deep brain stimulator, or you would consider vagal nerve stimulation, and then you have to go with what risks we're willing to tolerate, and for now, what is FDA approved, which is the vagal nerve stimulator. For the responsive neurostimulation, this would probably be more appropriate for someone who you know where there's maybe 1 or 2 discrete sites where the seizures are coming from, and these patients are not epilepsy surgery candidates. All right, so this is another slide from that same study, really putting the side effects head to head. And what we see here is not so surprising, that the vocal changes, the hoarseness, and the coughing we see in patients with vagal nerve stimulation. We don't typically see that in patients with deep brain stimulation or responsive neurostimulation. We do see the side effects of sensory problems such as the paresthesias or dysesthesias more often with the deep brain stimulation or the responsive neurostimulation. Infection is more common with these devices that are implanted in the brain as opposed to implanted in the chest and the neck. Okay, so let's pause right here. We have now gone through the different nuclei that you can stimulate through deep brain stimulation and why you would consider those different sites, such as the anterior nucleus of the thalamus, the centromedian nucleus, the subthalamic nucleus, or the cerebellum. And we have also discussed the different, the responsive neurostimulator or the NeuroPace device and which candidates those would be appropriate for. And we've looked at those head to head to get a better sense of who would benefit most from these devices. I just want to go back to the side effects for a second, because I'll tell you right now that one thing that you don't see again, which is significant, is you don't see sleepiness. You don't see drowsiness or cognitive slowing becoming an issue for these patients. And that's something that's worth keeping in mind as opposed to many of the medications that we have where that's a very common side effect. So before we move on to the next step, so just to be clear, we have gone now through all of the implantable devices, vagal nerve stimulator and these other devices that we've just discussed. So now let's talk about the external devices. So the first one here is trigeminal stimulation. The trigeminal nerve is another cranial nerve, like the vagal nerve, but the trigeminal nerve, instead of affecting different internal organs in the body, is really responsible for sensation in the head and the face. And so the idea here is that if we can stimulate the sensory nerve to the face, then this signal can go through different parts of the brainstem and into the thalamus, which then can spread throughout the brain. So a similar idea to the vagal nerve stimulator. It turns on, turns off at certain times, and you're trying to affect the brain, but here it's through an external device. So this is what's being currently studied. The group that's looking at this most heavily is NeuroSigma, which actually comes from neurologists and neuroscientists from UCLA in California, and it's a device that kind of looks like an iPad, and then there's these pads that you put on the forehead. The last study that I have is a phase 2 study from 2013, where they placed the device on, and it would stimulate for about 12 hours a day. So typically, when you get home and sleeping at night, they looked at 50 patients and they randomized them. It was a randomized control study for about 18 weeks. And what was found was that about 40% of patients had their seizures cut in half, which is significant. The problem here is that 50% seizure responder rate was not that different from the control group. So maybe there's a placebo effect that we don't know about, but really there was not enough of a statistical significance. It's probably not due to a placebo effect, but really just there was a small number of patients being studied, and we need a study with a large number of patients. So the side effects would be skin irritation, not surprising. This is an external device, headaches, and some anxiety, which I guess is also not so surprising to have those other 2 side effects as well. But that's interesting. It's no surgery needed, and this may be very helpful for reducing seizures. So that would have a better side effect profile compared to these other implantable devices. Transcranial magnetic stimulation is very much in the research phase of things, and the way this works is a magnet, which is this here, is placed up to the head and is essentially sends a electrical stimulus to affect part of the brain where you believe that the seizures are coming from. So this is not for generalized epilepsy. It's really for people who have partial or focal seizures, where the magnet is placed close to the area where the seizure is coming from. I've actually had it done to me when I did my epilepsy training at Boston Children's, and I just tried out the device, and it is uncomfortable. It's not so pleasant. But it's a non-surgical therapy. It's external, as we've discussed, but it's really only for focal seizures. How well does it work is another question. So the results are very mixed. Theodori at the NIH found a mild and short-lived seizure reduction. Fregni in 2006 showed a significant seizure reduction and an EEG improvement, but Cantanello a year later showed that there was significant EEG improvement, but there was no real change in the number of seizures. So to have EEG improvement without a change in the number of seizures is not really what we're going for here. We're really looking to improve the seizure control. So the results are mixed. Why are they mixed? So first of all, not so many patients have been studied, right? So just to go back for a second, 24 patients in one trial, and 21, and then 43. So it's really been a low number of patients that have been studied. The anatomy of the stimulation is significant, meaning that the brain is not a flat surface. It is a curved surface, and it's curves upon curves. There are different folds throughout the brain. So if you have a seizure generator that's coming from a fold within the brain, the magnet may not be able to reach that fold. In addition, the studies use different types of coils, different types of magnetic coils to send this electrical stimulation. Either a round coil, looking like a donut here, or this figure of 8 here. So the whole dynamics are different depending on what type of coil you're using, what part of the brain you're trying to stimulate. Okay, so we have now gone through the external devices that do not require implantation. These are not FDA approved. They are still in a research mode in terms of trying to see how effective these will be for patients with epilepsy. I want to be clear with all these devices, none of these devices make people seizure-free. So these treatments of neuromodulation is palliative. It is meant to decrease the number of seizures. It is not, it will not get a person to be completely seizure-free. It will not get a patient to be off of all seizure medications. That is not how these devices are intended to be used. Only the vagal nerve stimulator and the responsive neurostimulator, known as NeuroPace, is FDA approved. So these, the deep brain stimulation, that we discussed before, using the using the anterior nucleus of the thalamus, which is a device produced by a company called Medtronic, is still awaiting final approval. It passed through the panel by a close vote. Actually, it almost didn't make it through, and so we're waiting to see if and when that will be approved. However, deep brain stimulation is being used in other countries for epilepsy and is also being used off-label. So, for example, for patients who may have a movement disorder and epilepsy, so they have Parkinson's and epilepsy, let's say, or chorea and epilepsy, patients are having a deep brain stimulator implanted to see if that would help not only the movement disorders but also the epilepsy itself. As you can tell, these devices are complicated, and which device is right for the right person requires a thoughtful process. And so this is why patients who we are considering using these devices need to be seen in an epilepsy center and need to have a team approach. First, for patients who are failing seizure medications, epilepsy surgery should be considered first. And a conference should occur between the patients, the families, the neurologists, the neurosurgeons, the neuropsychologists, the social workers, the nurses. All these people need to be involved in a team decision to decide what is the best therapy for the patient. And if it's felt that maybe neuromodulation or neurostimulation is the next step or the right step, further discussions have to occur between all these parties to determine what type of neurostimulation or what type of neuromodulation is the most appropriate. And again, just to end this, that stimulation can be very effective, but it's not a cure. It will not cure a person with epilepsy. But the goal here, unfortunately, because we don't think that we can cure them with this electrical stimulation, we do feel that we can improve their seizure frequency and ultimately their quality of life, which is incredibly important. So I want to thank everyone for your attention this evening. We've discussed a lot, and I'm sure there are a lot more questions. So please feel free to respond to the email that you will be receiving in your inbox regarding any of the things that we have discussed here. I'll be happy to respond, and we should keep these conversations going in the neurologist's office to try to find what will be the best therapies to help our patients and those that we care for. Thank you very much. Have a good night.